My name is Nakona Sise, and today the camera can work with you now the Ministry of Information and Communication for witness the urgent press briefing where NaCOVERC called for. We go inside the conference room now for listening as experts them. They talk on how they do for fight this sick called COVID-19 for Komotna Salon.
We are fully aware that the world is engulfed in the third wave of COVID-19 pandemic, and Sierra Leone is not an exception. As a matter of fact, there are some countries now that are talking about the potential for fifth wave. As the World Health Organization and other instructive institutions have been indicating, COVID-19 will be with us for the longest haul. The National COVID-19 Emergency Response Center is a multi-pillar structure. It's an interagency structure. It draws personnel and best practices, institutional and structural, from a wide range of professional areas. And today we are pleased to recognize the fact that we have a multi-expert structure. We have experts in a wide range of fields who are here, and they are put at your disposal, our friends in the media, to respond to critical and emerging issues. First, we would have to have a presentation from the chairman of the National COVID-19 Emergency Response Center, Honorable Sheku Fantamadi Bangura, and then questions coming in would be responded to by our team of experts. Just for us to have a sense of the experts in the room, I would kindly ask our colleagues at NaCOVERC and the Ministry of Health and Sanitation to do self-introduction, your name, your designation, and the mandate of your pillar. So I'm sure that one would stimulate or prepare the minds of our journalists to frame questions as and when they touch and concern the relevant fields. So I may wish to start with Colonel Hassan Kumba, and then we'll take the rounds, please.
Thank you very much, Spokesman and Minister, Deputy Minister. So, colleagues, I am Group Captain Hassan Kumba. I am the Operations Coordinator at NaCOVERC. Short of my responsibility is to provide the enabling environment for the other pillars to conduct their activities in terms of operations, coordinating operations, and security. Thank you.
I am Professor Fodisa. I am the Technical Group Coordinator. I coordinate the activities of the various pillars in the technical arm of the response.
My name is Moses Devao. I'm the laboratory pillar lead for COVID-19 response. My duty is to collect, transport, and analyze samples for COVID-19.
Good afternoon. I am Dr. Tom Sise. I'm the pillar lead for vaccination, COVID-19 vaccination. So of course that entails ensuring that we have the vaccines in the country and the vaccines are distributed and eligible populations are vaccinated for us to have the necessary level of population protection needed for us to end the COVID-19 pandemic. Thank you.
Excuse me, please.
Yeah, good afternoon, everyone. I'm Dr. James Sylvester Squire. I'm an epidemiologist and program manager for National Disease Surveillance for the Ministry of Health. Epidemiologist and program manager for the National Disease Surveillance, Ministry of Health, and part of the surveillance pillar, NaCOVERC.
Good afternoon, everybody. My name is Aaron Thomas, Risk Communication Lead for NaCOVERC. My duty here is to communicate risks and event information and to give sound and accurate information in order for us to influence attitudes and increased knowledge.
Man with the suit. Oh, come there, sir.
My name is Alfred Jamiro. I am the lead for social mobilization. My pillar serves as the forerunner to all of the other pillars in the area of sensitization with the hope of changing behavior. Thank you.
Thank you. My name is Mohamed Haji Kela, lead for psychosocial, also deputy minister for
So, you know, the man with the bald head, the Michaela.
Dr. Van is the name. I'm the Director for Health Security and Emergencies in the Ministry of Health and Nutrition. At the same time, the surveillance pillar lead.
Hello everyone, my name is Michaela McKay, the Chief Operating Officer and Director of the SDI. We provide ICT support to the response, working with local and foreign ICT experts.
Good morning everybody, I'm Julia Spencer, Strategic Advisor, Public Information, NaCOVERC.
Good afternoon, my name is Alpha Khan. I am the Strategic Advisor for Social Mobilization and Food Security at NaCOVERC.
Thank you very much for the introduction. And as I said, we recognize the presence of the distinguished chair for the National COVID-19 Emergency Response Center, Honorable Sheku Fantamadi Bangura, who will be doing us a key presentation. After his presentation, we would ask the respective pillar leads that are here to do 1 minute brief each. Following the presentation of the chair of NaCOVERC, the respective pillar leads will do 1 minute presentation each. Just a 1 minute brief on the respective pillars, and those ones would inform the questions, comments, or suggestions that would come from the floor. Without further ado, I wish to give the floor to our distinguished chair, Honorable Sheku Fantamadi Bangura. The floor is yours, sir. Thank you.
Thank you, Honorable Solomon Jamiro. And thank you all. Thank you, Fort Estate. Thank you, colleagues. We are very pleased to brief you again. We've been doing this very regularly in the response, but I think this is the critical moment that we must bring to you clarity on where we are in terms of managing the third wave, which we had at onset of the month of June have been experiencing in the country. I must say, as I speak as of today, we have actually bent the curve on the third wave. And what I mean by that is when we look at our epidemiological curve and data, we are seeing decreasing number of positive cases in the country. And that we have been observing way back, I would say, since the end of June. But as you know, how did we get there? I think it is very important to get to where we are. We are seeing decreasing number of hospitalization. We are also seeing the death levels are not as high. We've been having, on average, 1 death, but sometimes 0 in the course of a week per day. That's not too alarmist, but it's something that we are watching very critically. We started off the alerting on the third wave with a surge. When we noticed slight rises in cases early in June, as a response, we surged our operation. We increased on the number of testings that we were doing on a weekly basis. We're doing an average of 3,500, but that gets ramped up to an average of over 5,500 on average per week. And what that did to, and then we followed up that with measures. to alert the population to adhere to the COVID-19 protocols of wearing face mask, social distancing, and ensuring that you pick up the hygiene protocols themselves. And what we saw is we pushed the curve right to its peak, way at the middle or towards the third week in June, where we had the 114 cases in the country. But because of those measures, we'd actually followed through once we hit the peak. We were not very sure about whether that was a true peak. We actually followed through with additional measures and clear pronouncement from His Excellency around curfew, limiting movement of people, and ensuring that also we stop what we call super spreader crowd gathering activities and puts further bans on enclosure facilities, would be the bars or clubs and the like. And then what we have seen towards the end of the month, second week in July, we plateaued the curve itself. There we saw the need to do what? Additional enforcement. And what we have seen in the course of all of this period leading to the middle of July is a complete epidemiological curve that has gone through a full quadratic behavior. What we are trying to do now is to ensure that we deepen our enforcement, we deepen our measures, and flatten that curve. As I speak, you will notice in the last couple of days, we've been hitting single digits on the case. We hope we should be able to keep that going, and that is the essence of the response. There are key indicators that are looked at internationally. One of them has to do with your positivity rate as a country. And WHO, what they do is they set a threshold of 5%. And we observe that very clearly as a country and ensure that we try and push our positivity rate relative to our test around that, below that figure. And as a country, what we have been looking at, in fact, is that rate, which we have seen it peaked around the highest number that we had, which is 114, around 10.2%. But that one has been coming down as I speak for last week, because we actually calculated on a weekly averages. It's about 3.1% now, way below the WHO threshold, which I think should give us some respite. We've been looking at the daily positivity rates themselves in the country, where you look at that to see whether your curve is actually flattening or actually going upwards. And what we are seeing is that this curve on the daily positivity rate in Sierra Leone has been flattened and is flattening actually. So what you want to do is to suppress it and bring it down, right? So as I speak, as of even the 17th, we were below 2% positivity rate, around that, around 2% positivity rate, which is what we have set as a threshold for ourselves. And the reason being, we want to ensure that our facilities, our capabilities are amenable to the way cases are actually emerging in the country. So we are confident that we are flattening this curve, and we must maintain it that way. We'll be looking at other forms of indicators to observe where we are in the response. Where they call the incident rate, the 28 days incident rate per 100,000 population. Sierra Leone is not among the list of countries internationally that are deemed to be with high transmission rate, which is if you have anywhere above 100 during that period, or 100 and 500 within that period, you'll be deemed to be high transmission case, or you're having increases greater than 50% in the last 2 weeks. So we have seen we are not among that list of countries at all as a response. And we currently are very confident that the way we have been calibrating the response, we are in a space where we must ensure that we deepen our interventions in terms of the measures that we have. Make sure that there is enforcement. You engage different stakeholders to enforce. On the vaccines, we do have vaccines in the country. And we have deployed the vaccines that we have, AstraZeneca and Sinopharm. We are encouraging the public, just like we did when we nudged the public, we are encouraging the public to take these vaccines. The vaccines are deemed efficacious and they meet WHO standards that we have in the country. And we encourage our people to take the vaccines. Two arsenal that we have to fight the virus. In Sierra Leone, we have gone through wave 1 and we have gone through wave 2, deploying our public health architecture, both in the way NaCOVERC is structured, ensuring that the command control operations are effective, but also ensuring that the public health interventions are robust. And that's what we used to go through wave 1, that's what we used to go through wave 2, and now we are going through wave 3 with the same measures. However, the second arsenal that we have is the vaccine. And that's why we encourage, but the vaccine in our space, the vaccine is something that we think Sierra Leoneans must take. And we encourage you to take the vaccines that we have. We do have Sinopharm, and Dr. Sise will speak to it. We do have Sinopharm in the country, and we are making every effort to ensure that we increase the stock of AstraZeneca that we have. So I want to leave you with that brief introduction that one, our hospital levels, bed hospitalization is low, and we have capacity to be able to surge or ramp up should we have increases in cases. We have been opening many facilities in the country should there be any change in the dynamics to be able to respond. There are talk around oxygen to support our case management. We have oxygen in the system to support our hospital under the current circumstance. And we are trying to improve on our result disclosure and use our epidemiology, the surveillance team to ensure that whoever tests positive, we're able to contact trace your primary contact. We've been improving on that, especially during the third wave. We've been improving on that, and I think there's a lot of slack that we have actually covered or squeezed out of the system. So that's where we are. I just want to stop there and tell the public that this corona is here, corona is in the world. It's not unique to Sierra Leone. The wave that we are going through is the wave that several other countries in the world are going through. Luckily for us, we've been able to put the third wave, sincerely under control, but we are still not out of the woods. We will still have the possibility of another wave hitting. So the only way you protect yourself, take the vaccines that are in country and ensure that you abide by the protocols that we have said. Mask up, social distance, avoid what we call mass crowd, which are super spreader events, and ensure that you follow hand sanitization. Let me stop there. I have technical people in the response that are advising each and every pillar. They should be able to speak to anything that I've missed out in terms of where we are. But you see, Sierra Leone was here listed and all of these things. All of that is something that we are handling diplomatically, because as far as we are concerned, the nature of the virus and where we are currently, we believe that the data doesn't tell us that we are in a red situation or a red state, right? So we are engaging internationally to ensure that the particular position is actually reviewed. So let me stop there, and I want to thank you very much. Our colleagues are open for questions after they have given their initial statements and contribution. Thank you very much.
Thank you very much, Chair. Thank you very, very much. So that gives us sufficient indication as to where we are in the fight against COVID-19, and also to indicate strongly that the measures as announced in the broadcast of His Excellency the President on July 1st are working. It is now our responsibility as Sierra Leoneans to make sure we fully cooperate so that we don't just deal with the third wave of the pandemic, or the pandemic generally. A significant hallmark of the efforts to address the third wave and the pandemic generally has to do with surveillance, our track and trace efforts. And there is somebody who is very competent to speak to our surveillance efforts and perhaps some other things that he would consider relevant to the process. And that is Dr. Vandy, the Director for Health Security and Emergencies. Dr. Vandy, you have the floor.
Okay, thank you very much for giving me this opportunity to discuss what we are doing as surveillance with the response. As it was put earlier by the previous speakers, surveillance is the forerunner for any response. Surveillance tends to break the transmission chain. That's why we trace and track positive cases. We give information to other response pillars as to what decision or what action to take next in order to break the transmission chain. We have been in this from the beginning. Because of our surveillance strength in this country, Sierra Leone was the last country in the sub-region to record a positive case way back in March 2020, 30th March 2020, when our neighbors have already recorded cases about a month. But even with that, people are saying, oh, we are lying. We are not lying. That is our strength. We have a very strong surveillance system in country. After the 2014-2016 EVD outbreak, frantic efforts have been made to support from the government and that of our partners to build a system, a resilient system, to be able to pick cases as early as possible. We have early warning system instituted in this country. We have community health workers in every community across the country. These are the ones who pick information on diseases across the country through the health system that we have established. We have immediate reportable events like maternal death, like EVD. These ones are reported immediately through the EIDSR system, electronic integrated disease surveillance and response system. We have instituted ECBDS, integrated case-based surveillance. So these are all systems that we have put in place to ensure that we have early warning system in country, to give us that leverage. The data the chairman presented here is collated by surveillance. We review that on a daily basis, and we also share that data with across the sub-region. It is mandatory that we share that data with the ECOWAS region. We also share it with other international bodies like WHO, like CDC. So they see all of this that we are doing. The surveillance infrastructure in countries also comprising of partners, both local and international. We have CDC, we have WHO, we have AFINET, all of them are part of it. So what we are doing is credible. It's credible. I'm one of the authors of the survey that was done regarding the surveillance that was published recently, and that has created some problem with some people in the community, in the country. Before that surveillance was done, there was a reason for that. COVID is one of the most, in fact, if not the most protracted pandemic that we have experienced for decades. This is the second year. And when you have a protracted pandemic of this nature, it creates a lot of problems. This has put to test every system, both weak and strong. We have seen how the American system handled the COVID case at the beginning. We have seen how other countries are handling the COVID case. There is no one size fits all approach to this. Every country has their own approach to the response to COVID. Before that survey was done, we had wanted to see what is the true prevalence of COVID in countries. So they tried to do a survey in Uganda and Tanzania. Well, it was limited to the mortuary. They were only testing corpses. So they came up with some interesting figure that they are seeing more positive cases among dead bodies. So it implies that there are more cases within the larger community that they are not seeing. So that information was made available to the respond in those countries to take appropriate actions. African CDC approached us that they want to do a nationwide representative survey. So Sierra Leone is the only country that have done a nationwide surveillance survey. We are the first to do, according to what we are told by Professor Eugene. We are the first country to do that. So we embrace it. Myself, my colleagues at EOC, we informed NaCOVERC, we informed the Minister of Health and Sanitation. We went through that. And the report that we got, which has attracted attention, is that, NaCOVERC have been underreporting. And this is what people are magnifying, and this is what people are making a lot of hue and noise about. That NaCOVERC have been not reporting the accurate figure. That is not the case. What the survey was saying is that it was nationally representative because we took samples across the country with help of Statistics Sierra Leone. We were able to go to almost every the various zones that we selected. We sent people out to collect data from there and to collect it. So this data was collected, and the observation was that it appears as if 48%, more than 48 times of the cases that they have seen in those communities is not what that we are reporting here. What does that mean? People are exposed to COVID. That was in March. People are exposed to COVID. And the asymptomatic cases, they usually take about a week for the virus to disappear in their system. A week. So if somebody is exposed at that time of the survey, 48, somebody is exposed to that. And they are now saying we have more, we are underreporting because they are saying we're supposed to have 48 times more cases than what we are reporting. That is not what the survey is saying. The survey is saying people have been exposed to it, they have antigen, they have antibody to the virus. That doesn't mean they are carrying the virus now. That doesn't mean they are carrying the virus now, but they were exposed at some time along since we have the outbreak. They were exposed along the line, but that doesn't mean they are not carrying the virus correctly. That does not what the survey is saying, because I'm one of the authors of the survey. But what we are saying is we needed to do more testing, and that is what exactly we are doing. Now the government have ordered for more RDTs that can give us the leverage to expand and do more testing across the country. We are asking for vaccination because the only way out to control this pandemic is to vaccinate your population to at least to get a herd immunity. Because if you can see Britain reopening their economy now, it's as a result of the fact that they have succeeded to vaccinate more than 80%. So they have got the comfort, the leverage now to open up. Even though they are getting cases, but those cases are not linked to hospitalization. But that's what they are telling us. Even though they are getting more cases, but they are not as serious to be hospitalized. And that was the fear. So if you only have the virus in you, you are asymptomatic and you are not hospitalized, because this virus is going to stay with us for some time. Not that we are going to eliminate it completely. It's going to be another Lassa fever that will be surveillance. It's going to be like even EVD. We are surveillancing Ebola up to today. We are surveillancing Marburg, which has not caused any outbreak yet. We are surveillancing Bombali Ebola virus that we discovered in Bombali 2 years back. We surveillance all of this on a daily basis. Not that they are here now, but we don't want for them to take us unaware. So we surveillance them. Likewise, COVID is going to stay with us for some time and it's going to be on our surveillance list. We're going to surveillance this for a long time to come. So that is what we know. As from surveillance point of view, it is not going very quickly. This is the second year. We know it's not good. We only need to control it, and that's why we have convinced the government. We have convinced NaCOVERC that the way forward is vaccination. We need to vaccinate more people. We need to encourage more people to take the vaccine, because we have seen the example now with England. We have seen the example in some countries in Europe that if you vaccinate your population to a level that you have created, have immunity, you can open on the economy. You can open up, because we are not going to wait to get rid of the last virus because we can open up. No. So we're moving in that direction. More testing and more vaccination, and that is the way the NaCOVERC is moving, and that's why we have advised government, and we are moving in that direction. Thank you very much.
Thank you very much, Dr. Vandi, and it's good you touched on the serologic study as well. For those of us who are following the international media, I'm sure we are privy to reports from India that is suggesting that 2/3 of Indians had actually developed antibodies. This is the new finding that has come out. So it's not just in Sierra Leone that you're having serologic studies. Chair, I recall in May last year, Kenya did one. In May, around May 30, Kenya had reported about 2,093 cases. Once the serologic study was done, it indicated a 4.3% seroprevalence, which was suggesting 1.3 million infections. In UK, the British Medical Journal also put out a study recently indicating that long COVID cases were being underreported in the records of the GPs. So it's not just in Sierra Leone where you're having serologic studies. This seems to be an emerging practice in most parts of the world. But what is important is don't just look at the finding and you conclude that NaCOVERC will be done the light away. No, we've run a very transparent system. Our figures are out on a daily basis, and as Chair has said, this is the pledge that we made. We made a pledge to the people of Sierra Leone that once we're dealing with the pandemic, there are some things that we have to jealously guard, and so transparency, accountability are some of the important hallmarks that will continue to define the response all the time. I wish to bring in Colonel Hassan Kumba, the lead for Operations Pillar, on whose shoulders rests the responsibility to enforce the measures as pronounced by His Excellency the President on July 1. Colonel Kumba to talk to us about operations, and after that we'll bring in Professor Givao to talk to us about testing. Thank you, Colonel.
Thank you very much, Spokesman and Deputy Minister of Information. So just to quickly take you through what Operations Coordination has been doing since the inception of the virus, and what we are doing currently following His Excellency's pronouncement. So this Operations Coordination, what we do, we take information or advice from the technical coordination, that is the technical people, the experts, and send that information into the Presidential Task Force. When once the Presidential Task Force gives directive for measures to be adopted, that is where we come in. We operationalize exactly what was advised and the measures that we had to take. So you will see we employ platforms like using the security sector. We bring in the police, the military, the intelligence, that is the Central Intelligence and Security Unit, and even the Office of National Security. So we bring them into the operation. We coordinate the operation with them and put them on the street. We also use the ICT platform to make sure, for example, as you may be aware, we have applications like the curfew e-pass, where we give passes to eligible people to be in the street, so that we have the curfew enforced. Additionally, we have been seeing lockdowns, restrictions issued out from time to time. This is wherein this coordination is done with all the pillars. And then we enforce the lockdowns. We make sure people don't move. If it is required that people don't move, we make sure people stay home. If it is required that they stay home. So this has been happening. Again, we have been seeing the compliance enforcement management system task force teams. You see security sector personnel in the streets asking people to abide by the enhanced measures, which is very key to this operation, because sometimes these measures are coming from the technical people, the experts. They have seen that these are the ways by which we prevent ourselves, so we are there to make sure they happen. Additionally, we coordinate operations at the airport, the seaport, and the border point of entry, whereby we make sure that before people come in, they are tested, especially those at the airport. Our passengers coming through the Freetown International Airport, we make sure that each and every passenger that is coming in or going out, they are tested. We make sure those coming in, when they come, their status, we determine how and where we keep them, whether we release them or if they are of concern, then we keep them for training. Then we also provide we look at the security at quarantine homes, treatment centers, community care centers, and even the recent rolled out vaccination program. So we provide security at those locations to make sure that insecurity issues are taken away from the response, and we make sure we do seamless operations. So recently, in the third wave now, what we are doing is enforcing the restrictions or the measures that have been announced. In doing so, we have revised the strategy. We are looking at engagement and enforcement. With the engagement, we want to make sure we engage the public. We want to make sure we localize the fight against this virus. We need people, you sitting here, even the village, those in the villages, each and every member of Sierra Leone, we want them, or citizens of Sierra Leone, we want them to be incorporated into this response. Because we have realized that the denial is still a challenge, it's creating a problem. So we think that engaging the populace, engaging institutions will be key in doing this. So for example, we are going to use the police heavily. They have structures in place, they have the police community programs, they have their partnership boards, they have the road transport sector, transport management, where they have traffic police. For example, there's a restriction on number of people that we process in funerals. So we want to make sure if people are passing, and for example, there's a traffic police that has seen more than 50 people, they can alert us. It could be a security layer so that people are informed. So as well, we are calling on the public. You please call us if you see the super spreader events, if you see more than the prescribed number of people processing with the funeral, we'll be grateful to have you. In fact, today, just after here, we'll be having another meeting with the Freetown City Council. Next, we'll be going to Ward C, that is the Western Rural Council, so that we engage them to help us with their structure. We plug into their system to make sure that when people come to ask for burials, they want to go to cemetery, even the security at the cemetery is involved in this response. By which way, they will alert us to say, okay, you have given for 50 people to come, but we now have more than 50 people here. We can give them the authority to make sure not more than 50 people enter. So these are the steps that we have put in place. We want to make sure that this is integrated into our communities. We are going to use our risk communication and social mobilization. They will speak to that, but we are now looking at enforcement and engagement. Thank you.
Because we don't have the luxury of space, perhaps the other speakers would wish to talk from the mics that are with you. So let's hear Professor Geval on labs. After Professor Geval, we'll hear from Michael Amaki on technology and Dr. Tom Sise on vaccination. Professor, please.
Yeah. Thank you very much. Good afternoon. Our duty is to determine through testing the presence or absence of the COVID-19 virus. That's all we do. We test different, we collect samples from different categories of people. We collect from alerts, people who are experiencing symptoms of COVID-19. These alerts go through 117. We are called upon to collect the samples. The next category is their contacts. And then if you are positive for COVID-19, if you are admitted, before you are discharged, you are tested again to prove the absence of COVID-19. Apart from that, we organize genomic sequencing to actually know the type of COVID-19 we are dealing with. And that was how we were able to determine that the Delta variant was in Sierra Leone. Testing is done in 6 laboratories in this country, 4 in the western area, 1 in Makini and 1 in Kenema. We actually use what we call the gold standard, is the PCR. In medical terminology, it's called polymerase chain reaction. This, we have a turnaround time from the time we collect the samples to the time you get your results is 48 hours. That's our turnaround time. I think that's about all. That's what we do. We give out the results and we facilitate patient management. Thank you.
Can you kindly switch it off, bro? Continuously press it to switch it off. Thank you, sir. Stella.
Okay.
Thank you very much. As mentioned in my intro, the STI provides support, ICT support to the response. So based on the needs, we come up with systems and solutions to see how we can improve the effectiveness and efficiency of the response. So thus far, again, some of you are fully aware of what has been done to date, but just as a recap, even with the government information portal, the *468#, if you go to that portal, simple USSD, you have access to COVID-related information, updates, symptoms, and tips. And this was also make sure we get rid of the fake or false news that's in the public domain with regards to COVID-19 virus. We have also worked with all the partners to see how we can upgrade the systems at 117 call center, because prior to COVID, it was an emergency call center, but we had to see how we can enhance the capacity to be able to take on the additional workload that they had. During lockdowns last year, DSTI, again with other partners, we supported monitoring of the lockdown, where some of you actually did see drones in the air to be able to advise governments and make sure they make this informed or evidence-based decisions on further lockdowns that could happen and whether or not we can actually sustain lockdowns for more than 3 days. We actually work with the mobile network operators, and using call data records, aggregated data, we analyze this data to be able to understand mobility, especially mean that the western area was the epicenter, to understand movement and see potential spread of the virus and how we can work with the respective pillars to curtail the spread. Colonel Kumba mentioned they're in charge of compliance, so we work with niche technology to see how they can roll out SIMS, that's a compliance management system, where if you are in default of the protocols and you have to pay fines, how these fines are monitored real time. Now again, for homes that are quarantined, it's also important to be able to monitor services that are being offered at these homes. So we supported the response by developing a quarantine app. As I speak, training is ongoing in Western area rural, where supervisors from both surveillance and quarantine team are trained on how to use this application, registering the homes as and when a positive case is detected, or even if they're primary or secondary contacts, being able to monitor psychosocial and other medical support services that are given to members in these quarantine homes up until when the home is collapsed as a quarantine home and they're all allowed to leave, provided they're all negative. Most importantly, the response is responsible for monitoring travelers in and outbound of Sierra Leone. So we're working with a company called Fixed Solutions to operationalize the travel portal, travel.gov.sl, which records and registers inbound and outbound passengers coming through the international airports. As I speak to date, we have, to be precise, 109,956 passengers that have registered on that portal. A couple of weeks ago, I did come here where I actually informed that we were launching the *1919#, and that's used by swabbers to record the point or time swabs are collected for international travelers. What that does is feed information directly into the portal. At the instance the swab is collected, the swab goes to the labs, and when the results are released by the admin center at EOC, provided they're negative, the passenger is able to access their e-certificates and they're ready for travel with the certificate downloaded on their mobile phones. So there's several ways we support the response. Very soon we'll also be launching, based on approval from labs, another solution where any other person, the subject, their data will be collected real time at points of testing, whether it's antigen or swabs, and also the results will be released real time. This all adds to the efficiency of the response and makes Sierra Leone also unique in its own way of addressing the challenges as and when they come. Thank you.
Thank you very much, Michael. So we'll now bring in Dr. Tom Sise on vaccination. After Dr. Sise, we'll bring in our two strategic advisors on public information and social mobilization. And Professor Fudisa may wish to say a word or two on any technical issue perhaps that we have not been able to speak to in a minute. Dr. Sise.
Yeah, thank you very much, Honorable Minister. Thank you very much, Mr. Chairman. Yeah, so earlier on, Dr. Bandi said that surveillance is the forerunner in the COVID response. We all know now that conclusion of the COVID response is through vaccination. If we want to open up the country, if we want to continue to do the things that we used to be doing, we need to ensure that we are adequately vaccinated as a country, so that we can resume normal activities. Of course, as the vaccination pillar, we are providing vaccination services across the country. Of course, at the moment we have 72 vaccination teams. We are planning to expand that significantly so that we can, increase the reach. We've been able to vaccinate 135,000 people with the first dose, and that's 2,607 have received the second dose. We are currently using 2 vaccines in the country, that is the AstraZeneca vaccine and the Sinopharm vaccine. Of course, you all recall that we received 96,000 AstraZeneca vaccines from the NaCOVERC facility, which was due to expire on the 16th of July. I'm happy to report here that all of those doses have been utilized. Of course, we would have paced the utilization of the AstraZeneca vaccines, but because they are expiring on the 16th of July, we had to expedite the utilization of those vaccines. Of course, we had also received 42,000 doses of AstraZeneca vaccines from the African Union. These are vaccines that were originally procured by South Africa, but because they were not effective against the South African variants, South Africa donated those vaccines to the African Union. And you all know, those processes, the bureaucracies involved in doing those donations, and from the African Union, donated to a selected number of countries. We were one of the countries that benefited from those 42,000 doses. They arrived in the country on the 20th of March, and they were due to expire on the 13th of April. So there was no way we were going to be able to use all of those vaccines. But we utilized 29,000, and 13,000 of them we could not use. So those vaccines are quarantined and for disposal at a later date. So at the moment, we have Sinopharm vaccines, and these vaccines are effective, they are efficacious. We know that normally when you compare vaccine against vaccine in terms of efficacy, you may have one that is 80%, 85%, but any vaccine that has an efficacy above 60%, I think has very good benefits in terms of population immunity. So we're going to continue to encourage people to ensure that we receive the vaccines. At the moment, we are working with international organizations. Even His Excellency, the President, retired Brigadier Julius Malabio, has been part of the advocacy to ensure that we get AstraZeneca vaccines earlier than the expected arrival date, which is in August. But a lot of advocacy is going on to ensure that we are able to get AstraZeneca before that date. Recent evidence is now emerging that even the Sinopharm vaccine can be administered even to persons over 60 years of age and people with comorbidities. Before now, we were limiting the Sinopharm vaccine only to people who are below 60 and people who do not have comorbidities. But now there is no excuse not to take the Sinopharm vaccine because the evidence now shows that it can be administered to all of those target populations. I want to remind all of us that for us to be protected, we need to have the 2 doses of the vaccines. So for all those who have received first dose, you need to ensure that you try and get your second dose. Have in mind that there's a global rush to get these vaccines by all countries. It's a highly competitive space. So when vaccines are available in country, we need to make use of that opportunity and try to get ourselves vaccinated as early as possible so that we are properly protected. We're having some preliminary data showing that there are a lot of benefits we are getting from the vaccines that are being administered in the country. Looking at some of the data from about 1,340 positive cases in the DHIS, out of 1,340 that are positive, 1,290 have not received any vaccination, right? And only 26 had received 1 dose of the vaccine, whilst 8 had received 2 doses of the vaccine. Only 4 of the positive had received 2 doses more than 2 weeks earlier. So this is preliminary data. A lot of data analysis is going to continue going forward. But you can see that the overwhelming majority of positive cases that we are getting now are amongst people who are not vaccinated. So we want to encourage people that the vaccines are effective, and I think we are getting the results that we are expecting. Of course, we are encouraging the district level, the NaCOVERC and the DHMTs to step up in utilization of vaccines, because we know some districts like Kaila and Kenema are doing extremely well, and we always want to commend them. We have some districts that are now, vaccination seems to be tailing off. We want to encourage them to step up so that we ensure that our people are adequately vaccinated. We are planning on expanding on the vaccination sites to 300, so that we have 300 vaccination teams across the country, and just to ensure that as we are expecting additional vaccines in August, unfortunately we'll be having a wide range of vaccines in August. We want to ensure that we have enough vaccination sites to ensure that we utilize all of those vaccines. So thank you very much, and we look forward to your advocacy, support, and joining us in mobilizing to ensure that our population is adequately vaccinated. Thank you.
Thank you very much, Dr. Tom Sise. So we have two strategic advisors with us on public information and social mobilization. And we believe that engaging communities and communicating risk is very important in the pandemic. I would have loved Harold and Alfred to have spoken on risk communication and social mobilization, but for the fact that we have those strategic advisors with us, we'll let them do the honors. And so Dr. Julia Spencer, and after you, Alhaji Al-Fakan. Professor Sir, would you wish to, at some point, make an intervention?
Sure.
After those two speakers. Thank you. Dr. Spencer, please.
Thank you very much. I'll keep it brief. Basically, the public information part of this response has been probably one of the most important. You'll be aware that a lot of information is put out. We started off with daily press briefings. They were reduced from daily when the pandemic went down. A lot of information is out on social media. We have a group of people we call Corona Affairs Ambassadors, about 50 of them, that we have engaged so that they can help spread the message. But perhaps most important is our coordinating efforts. What we want to be able to do by the end of, by the end of the pandemic, the virus will still be around, we believe, is that there should be systems in place that can be utilized in future pandemics, because everybody knows across the world that there are going to be other pandemics. Ebola came and went, and the systems that were left behind were basically challenged when COVID came. In terms of information now, we have built networks. With all the districts, we even have weekly online meetings with the risk communication, social mobilization, public information teams in every district, so we can coordinate what they're doing, their activities, and we can get feedback. We're doing monitoring of the media, we're monitoring rumors and misinformation. We have a system in place which gives us an indication of what is going on, what people are talking about, the wrong information that is going out, and we're making efforts to counter them. So a lot is going on. I believe that the public information and risk communication and social mobilization cluster of pillars is being taken very seriously by NaCOVERC, and our activities are going to receive significant funding so that we can ramp up our response. We've got assurance of that. So in the next few weeks, you are going to see that part of the response ramping up, because we believe that this pandemic, in fact, the evidence shows that it is probably one of the most difficult that the world has faced. And one of the biggest challenges now we're talking about infodemics. Basically, the false information out there is so much that people are confused. Across the world, it's not just Sierra Leone. So we are making frantic efforts to be able to counter that false information so that people get the actual information they need so that they can make informed decisions. Thank you.
Thank you, Dr. Julia Spencer. Alhaji Al-Fakan.
Thank you, Mr. Spokesman, Mr. Chairman, and all of our colleagues in here. Good afternoon. What we do is to encourage people to prevent themselves from getting sick. As they say, I think the very first basic principle of medicine is that prevention is better than cure. And if you prevent yourself, you won't have to give the doctors so much work. So far, we have been lucky in Sierra Leone. We have about 6,300 cases out of 7 million. It's less than 0.1% of the population. What we have, that is an emergency for us in social mobilization. And the rest of us, you, me, and all of us, over 6,999,000 people that we need to fight to keep safe. And we can only do that if we cooperate with you. The press, politicians, the traditional rulers, the headmen, the youth, and everybody that is out there is a social mobilizer. So we'd like you to help us take the message across to the people that this disease can only be defeated or avoided if you continuously wear your face masks, wash your hands, and keep social distance. And that also, if you back it up with the vaccines, as Dr. Vandy and Dr. Tom Sisi have said, that will help us. Because the doctors have said and they predict, and when they talk, sometimes you have to know. They say there's going to be a 4th and a 5th and a 6th wave. All of you are familiar with Lumley Beach. Anytime you go there, you see the waves coming. There will be a big swelling. It will break, but another one is coming. What we are doing in NaCOVERC is to try to rectify those waves, so that we keep the troughs low and, like Chairman said, to bend the curve. Once we bend the curve, we'll then maintain parity. And when we do that, even if the pandemic stays with us, the corona stays with us, it will not come to the proportion of a pandemic because we've been able to break the outbreak. So that's what we do in social mobilization. Let the people know that the responsibility for you to stay alive and also for other people to stay alive is for us to observe the precautions that have been put across. So thank you very much, and we will continue that. It's a responsibility as patriots and nationals of Sierra Leone. Thank you very much.
Thank you very much, Alhaji Alfakan. I also wish to acknowledge the presence of Darlene Yema Thompson, the Managing Director of Sierra. And Yema was actually the person who helped us put through that fine team of about 60 Corona Fit ambassadors we call Shia Fumama Salon ambassadors. Thank you very much, Yema Thompson. So we listened to Michaela McKee when she was talking about one of the beautiful things happening in the response is the fact that we have been able to design and deploy technology throughout. So when there was resumption of commercial flights, when we lifted the restrictions then for the second wave, we were able to set up the travel portal, www.travel.gov.sl. So we're seeing incoming and outgoing passengers, and I'm sure at the start, Sierra Leoneans were deeply concerned. Will NaCOVERC get this right? We have been able, under extreme difficult circumstances. So I would want to bring in Honorable Mohammed Haj Kela to talk about how the interventions at the Freetown International Airport have been able to address some of those things. And now that we have the systems working, Honorable Haj Kela.
Thank you very much. Our role at the airport in terms of NaCOVERC is really trying to operationalize the architecture that was set up. You will recall that there were quite a lot of glitches when we started the response in terms of actually making sure that we gatekeep, if not try to prevent the virus itself from actually filtering into the country. What that meant was that we needed to make sure that every traveler coming through our point of entry, particularly the Freetown International Airport, must be tested or screened and then allowed to come into Freetown. So far, on average, we are receiving about 1,020 to 30 passengers every week coming into the country. And what we do at the airport is to ensure that all of them are screened through our portal system, as well as actually making sure that they are tested. In the beginning, people were a bit questioning, will we get this right? What we have done so far is to ensure that we put the right system in place, and we put the right capacity of people that will be able to manage that process for us, right from the lab process, making sure that the operation is right, ensuring that those who come through our testing are fully briefed, psychosocially insured. Once they have received their test results, if they are with the RDT, the rapid response test that we're using, in the first instance, if they are not reactive to it, then we allow them to proceed to preterm whilst they await their PCR results. If they are reactive, what NaCOVERC does, we do have our holding centers that are very clearly put, well measured, and of course anyone can stay there without any cause to say, well, this is not good, we don't have this, we don't have the facilities. But when they are reactive, we keep them in our holding centers, which will be at their choice. If you want to go to hotels, then they can go to the hotels. So far, we have expanded on our testing facilities at the airport, using both sides. Those who may have gone through the last couple of weeks, you will see that there have been quite a lot of improvement there. And I would also like at this juncture to also let you know, as part of our legacy, strengthening our health system, we are actually putting up a structure, a testing facility, which will be able there to manage quite a lot of work, particularly when it comes to testing. So far, we have worked with the airport management, NaCOVERC, and of course other partners to make sure that the passenger experience is really a real one, and people are not actually crowding or clustering in our testing. Some of these pictures or films you might have seen on the social media, that is now a thing of the past, or things are working well. So thank you very much.
Thank you very much, Honorable Keller. Brigadier Professor Fodisa is the technical coordinator in the response. He may wish to add one final layer to the technical brief that has been provided. After that, we'll be pleased to take your questions. Brigadier Professor, please.
Thank you very much, Spokesman, Mr. Chair. My colleagues actually have spoken to most of the points, but I would like to highlight a number of things. One is the case management. Case management has to be made known to people that what case management did was they responded well to the third wave. The third wave coincided with the time when we were actually drawing down. That is when we are downsizing. But as a response, they quickly reacted by actually seeking the approval of administration so that we can bring in more doctors and nurses to respond to the third wave. Hence, more admission beds were created. We created more admission beds. And then we also expanded on the home isolation. That is why people did not hear about the did not hear any noises like what we had in the first and second wave, because the home isolation architecture was expanded. Most of our positive cases, asymptomatic, were kept at their homes, and we had a team that actually visited these people in their homes to make sure that we actually gave them the appropriate care. And the case management also went out to do a survey of the oxygen facility, because that was also some noise in country about oxygen not available, oxygen being available, which was actually misinformation. The country currently has enough oxygen production that can serve the response. So the case management went out to actually identify all the centers, both public and private, that produce oxygen, so that this oxygen supply can be made available to the response. And that is what we did, and then everybody that needed oxygen was provided with oxygen. Some people, I mean, because some families decided to provide oxygen, we did not stop them. But as a response, we provided oxygen for all those that needed oxygen. I want to emphasize on local content. From the experience of Ebola to COVID, in this response, no international body or no person from the outside was brought in to tell us what to do. You can see that all the pillar leads are Sierra Leoneans. During the Ebola response, a lot of expatriates came in to actually guide our processes. We worked with our partners, but all the pillar leads actually are Sierra Leoneans, and we responded well to this epidemic. And Dr. Vandy spoke something about the seroprevalence survey that was done. I just want to throw a little light on that. That is, the seroprevalence survey just tells you that you were exposed to the virus, but you do not have active infection. You can have active infection, antibodies will be present. You may have been exposed years ago, and you can still manifest antibodies in your system. We did a survey some 5 years ago or so, and even we identified certain viruses which have not been identified in this country for over 50 years, but we found people that manifested antibodies to those viruses. Virus like chikungunya, for example, Rift Valley fever, the Zika virus, the Marburg virus, as stated by Dr. Vandy, for example. All these viruses, we identified people in the mountain rural district who had antibodies to this virus, but these viruses have not been identified in people with active infection over the past 50 years. So the survey that they did just tells you that these people, it's possible, even Ebola, we identified people with Ebola, with antibodies of Ebola, even before Ebola struck, when we did a survey in the mountain rural district. So these are some of the things that people need to understand, that NaCOVERC did not underreport anything. We actually reported the test results that we do on a daily basis. So in effect, those are the things that I wanted to add that we are doing as a response.
Thank you very much, Media Professor Folisa, for the clarity. And I think we've been able to bring it. It's always easy to have this team of experts in an emergency, to bring all of them together under one roof. It's extremely difficult, but I'm sure we've been able to do this with communication and social mobilization. We've been able to do this like every 2-3 months, and so we are happy that in the third wave, and as the chair indicated, that we're doing everything we can to change the directory of the epidemiological curve. We'll always get these experts to speak to us.